Hello and welcome to Calcium Masterclass Class 8, brought to you by Shockwave and Optima Education. I'm Jonathan Hill and I'm a consultant cardiologist at the Royal Brompton Hospital here in London. And today in the studio, I'm delighted to be joined by Course Director James Spratt, Professor in Interventional Cardiology at St George's Hospital in London. James has been responsible for putting this whole course together, so thank you, James, for making it happen.
Thanks, Jono. Great to be here with you. Today's session is all about clinical evidence and algorithms. And to get to grips with this subject, we have invited some of the world's top experts. Firstly, Matthew Price will be joining us from Scripps Clinic in La Jolla, California, to ask what's the plan, the role of algorithms.
Benjamin Honton will be reviewing IVL data to date and asking where are the gaps. And finally, Ashok Seth will be telling us about the Indian experience.
But to start off today, I'd like to invite Jonathan here to walk us through the CAD3 study. Jonathan, it's over to you.
Thank you, James. It gives me great pleasure to present the Disrupt CAD3 results. The Disrupt CAD3 study was a prospective, multi-center, single-arm global IDE study carried out in 4 countries. Here's the study design. The target population was heavily calcified de novo coronary lesions with a reference vessel diameter of 2.5 to 4 millimeters with a stenosis of more than 50% with a lesion length of less than 40 millimeters. There was 1 roll-in patient per site, and there were 47 sites in total. We had an OCT Substudy, which was led by Richard Schlofmitz, and the ITT population was 384. And we have presented the results and published now the 30-day follow-up. We're looking forward to presenting the 1-year follow-up at TCT later this year. Here is the Disrupt CAD3 study design. This is a prospective multi-center single-arm global IDE study carried out in 4 countries. The target population was heavily calcified de novo coronary lesions with a reference vessel diameter of 2.5 to 4 millimeters. With a lesion length up to 40 millimeters. There were 47 sites in total, and we had a roll-in population of 47. There was an OCT Substudy carried out by Richard Schlofmitz, and the ITT population was 384. We have published and presented the 30-day follow-up results, and later this year we'll be presenting the 1-year follow-up. These are the major endpoints. There was a primary safety endpoint, which was freedom from MACE at 30 days, including cardiac death, myocardial infarction, and target vessel revascularization, and a primary effectiveness endpoint, with procedural success classified as successful stent delivery with residual stenosis less than 50% and without in-hospital MACE. The secondary endpoints you can see listed here. The statistical methods were based on the predicate Orbit 2 IDE study. So we were enrolling similar patient population with similar endpoints and definitions. And a relative risk of 1.5 was utilized using the universal definitions. The primary safety performance score was 84.4%. You can see the calculation there. And the primary effectiveness performance goal was 83.4%. Statistically, this gave a power of approximately 81% for both primary performance goals with a one-sided type 1 error rate of 5%. So there was an expected freedom from MACE at 30 days, gives you an 89.6% power, and procedural success just under 89%. These are the baseline clinical characteristics. So 3/4 of the patient were male, the average age over 70, the expected range of cardiovascular risk factors, and a few patients, just under 10%, who'd undergone prior bypass coronary artery surgery. The angiographic characteristics, just over 50% were LAD lesions, and just under a third were right coronary lesions. The reference vessel diameter was 3 millimeters, with a minimum luminal diameter of 1.1. So a diameter stenosis of 65%, and with a lesion length of 26%, but with a calcified lesion length of just under 48 millimeters, which is the most complex calcified population studied to date. So 100% of these patients included in the study had severe calcification. Here you see a graphical representation of the angiographic outcomes with a pre-procedural stenosis of 65.1%, reducing to 37.2% with intravascular lithotripsy. So a substantial reduction in the stenosis following lithotripsy alone, and then a significant further expansion and residual stenosis of just under 12% with a final in-stent result. And here you see this cumulative frequency shift of the frequency of the stenosis versus the MLD. The in-hospital and 30-day MACE are represented here. So a 7% in-hospital MACE rate, all myocardial infarction using the universal definitions, in-hospital 6.8%, non-Q wave MI 5.7%. And we see in the 30-day column 7.8% MACE at 30 days, 7.3% all myocardial infarction, and 6% non-Q wave myocardial infarction. The cardiac death, Q wave MI, and target vessel revascularization you see listed below. With the secondary endpoints, looking at peri-procedural MI, using our per protocol definition was a 6.8% rate, with using the fourth universal definition 7.3%, and then using the more contemporary SCAI definition 2.6%. Here we see the target lesion failure at 30 days of 7.6%, with all revascularization 2.6% and stent thrombosis 0.8%. These are the procedural characteristics, and we've compared the OCT substudy patients to those with angiography alone. So pre-dilatation was carried out in 35% of the OCT guided patients. With angiography, that rate went up to 60%. Similar numbers of IVL catheters used. The inflation pressures corresponded in both the OCT and angiographic arms. The mean number of IVL pulses was similar. Post-IVL dilatation carried out in 1 in 5 patients, and the numbers of stents just over 1. Post-stent dilatation was carried out in 100% of cases, and the total procedural time was similar. When we look at the mechanism of action, so understanding how intravascular lithotripsy is working, we're looking for calcium fracture characteristics. And these were the details that we obtained from the OCT substudy. Interestingly, we saw no fracture in 32% of patients post-IVL. So the macroscopic fractures that you can see on OCT were not visible. Post-stent, we saw that there was 30% of patients had no fractures visible. Single fractures were observed in 21% of patients post-IVL, and the similar number after the stent implantation, and multiple fractures were observed in just under half the patients. The fracture depth measured by OCT was 0.48 millimeters, and the fracture width 0.55. And what we see with the stent expansion is that the fracture width then expands following IVL and following stent implantation. What this information tells us is that the mechanism of action is likely to be calcium fracture visible by OCT, but there is an additional mechanism of action which suggests that microfractures may be playing a part in the expansion characteristics of a calcified lesion once treated with IVL. Here we see the outcomes by fracture visualization. The MSA was 6.3 millimeters squared and 6.8 millimeters squared if there was no fracture. So it doesn't appear that the presence of fractures, of the macrofractures that we saw in OCT, are the sole mechanism of action. This suggests that it's the microfractures that I've just described may well be contributing to the mechanism of action. So a combination of macroscopic fractures that you can see on OCT and microscopic fractures which change the vessel compliance and allow stent expansion. And the consequence is that stent expansion, which is the goal of intravascular lithotripsy, maximizing stent expansion, was over 100% in those cases where we saw fracture as well as with no fracture. And the luminal stenosis, the MLA at the end of the procedure following IVL and stent implantation and stent expansion to over 100%, with a residual stenosis of 22% in patients with fractures present and 20% with no fracture present.
So thanks, Jono, for that great talk on CAD3. I mean, I know you've been involved since the inception in this program. And you highlighted a couple of interesting points about this study. The first was obviously coronary calcium. It's not something which has really had such a granular study before. And I guess the questions that we'll be asking on the other side of that fence is, were these lesions really calcified? And if so, what's your confidence that these were really resistant lesions?
So I think there's a very high degree of confidence that they were very heavily calcified. Really 100% of the lesions within CAD3 were defined as having severe calcification. So the assessment of calcium was firstly, for selection of the patients, done using conventional angiography. Mm-hmm. And what we're seeing now with some of the new imaging systems, the much better resolution, is in fact we can identify calcium much more readily on angiography. Mm-hmm. And so we're becoming much more sensitized and aware that a lot of the patients we're dealing with have a heavy calcium burden just by angiographic features alone. Yeah. So one of the particular aspects that was looked for to define near concentric calcification was when you saw calcium on both sides of the vessel in two orthogonal projections. So if you saw that tramline appearance, you knew that there was likely to be a near concentric ring of calcium at that segment of the vessel. The confirmation of the burden of calcium that was then with the OCT Substudy, so in 100 patients in Disrupt CAD3, was really the way of providing further confirmation of extreme calcification, so that the concentricity and also the depth of calcium was measured with a very high degree of precision. Mm-hmm. So I think there's angiographic inclusion criteria for calcium, and then confirmation of the calcium burden was done by OCT. So I think it's beyond question that these were heavily calcified vessels, and 100% of the lesions would fall into that category.
So it's interesting, Jonathan, we've had, of course, a separate class on imaging of coronary calcium, and I think what we learned from that class is that if you see significant calcium on an angiogram, it's generally the real thing because it's highly specific. It's not very sensitive, but it's highly specific for calcium. So, and actually it may well be that coronary calcium on a coronary angiogram matters more than noticing a bit of coronary calcium on intravascular imaging. So it may well be as an inclusion criteria, that's a decent inclusion criteria. I suspect in clinical practice, you wouldn't want to necessarily rely on just angiographic calcium. And that's the second point I wanted to come on to with the OCT. What was the thinking behind the OCT Substudy? Because this is quite an interesting development, isn't it? This kind of combination of intravascular imaging to guide therapy. It's not something we've seen a lot with kind of device-based therapy before.
I think there were two reasons for using OCT. One of them was to look at the mechanism of action. And really, as an intravascular imaging modality, OCT is ideally suited for that. It gives you a very high degree of spatial resolution, and you can image calcium very clearly, both by looking at concentricity as well as depth. You really only get the concentricity information from IVUS. You don't get the actual because these sound waves do not penetrate with it into the deep calcium. Mm-hmm. It's only really with OCT that you can see that level of detail. So the first reason was to demonstrate the mechanism of action. But the second reason was to introduce the concept of optimized PCI into the treatment of calcified lesions. So in the OCT Substudy, we were really implementing all that we'd learned from non-calcified lesions about optimizing stent expansion. And so all the rules that we've learned from for example, the Illumian studies about sizing the vessel using the external elastic lamina, looking at the distribution of calcium along the length of the lesion and where we need to direct our calcium modification. All those factors were brought to bear on the optimization part of the imaging sub-study. So firstly, you showed the mechanism of action, and secondly, it was about delivering optimized PCI.
Yeah, and let me be difficult, Jonathan. It goes against my nature because I'm normally not a difficult person, as you know, but surely that study is not powered to show difference in stent outcomes. It seems to me, and actually, please correct me if I'm wrong, but it seems to me that's more an illustration of a direction of travel in terms of how we should be going, rather than to say this is a hard line in the sand. It's more a kind of, actually that's what represents optimal calcium treatment.
Yes, well, I think it did represent optimal calcium treatment, because what you saw in the conventional endpoint of MSA, so the minimum stent area, which, as you know, is the key endpoint for the Illumian 4 study, which is the world's largest OCT study, which did include a subset of heavily calcified patients, including shockwave patients. What it showed is that, like the non-calcified lesions, that you can achieve full stent expansion. So yes, it wasn't. There's no outcome measure. The procedural success was obviously measured, and it's notable that the stent expansion was 100% in all of the in the CAD3 sub-study. That there was very clear, fully optimized PCI at the end of every procedure, guided by OCT.
So you were involved in this study from its inception, Jonathan, and I know that process is a very involved process, and of course you should be rightly proud of the results. But part of a research process is actually learning lessons. So what lessons did you learn, and actually what would you have changed if you had to do CAD3 over again?
I don't think I would have changed anything. And I think huge credit should be given to the study team that delivered this trial. In fact, we've completed recruitment just before the pandemic, so March 2020. And that was a huge achievement. We'd recruited on time to target, and very enthusiastic group of physicians engaged. So, and that characterized all of the CAD studies. CAD 1 and 2 done in Europe, CAD 3 in the US as well, CAD 4 was the Japanese study. But those studies were really focused on the safety of the procedure and the procedural efficacy. So I think they answered those questions, they answered them very well in a definitive manner. What you were involved in parallel, the moment that the CE mark was granted after CAD 1, was really exploring the whole range of options of the sort of the unmet need, the gaps that the CAD population was very targeted, and I think had to be targeted to compare to previous studies. For example, the CAD 3 study was really done as a direct comparison to the predicate Orbit 2 IDE study. So that was a requirement for the FDA, and it answered all the questions. We answered all the sub-study questions about the safety from an electrophysiology perspective. And in fact, the concept that you, I think, first described, shock topics, became an integral part of one of the sub-studies of CAD 3. We had I think a comprehensive look at the safety of this device, and I think that's why I wouldn't have changed anything, because I think it answered all those questions.
Yeah, and it's obviously it's naive to expect a study to answer every question, and I think actually that's sometimes a mistake you can make as well, being too ambitious in the study. It was a discrete population of relatively circumscribed calcific lesions. But as you know, the real world is very different to that. And actually, the first thing we want to do as physicians is be curious and say, well, will it work in this scenario? Will it work in that scenario? And I think that's one of the reasons we asked Benjamin to talk on that subject. So just one further topic on that, away from CAD3 completely. And I want you to speculate on the management of calcific coronary disease within acute coronary syndromes, and particularly ST elevation MI. Because that's like a grey zone at the moment.
Sure.
What is happening?
Well, I think it's a really good question, because within acute myocardial infarction, there is this idea that we have to do things quickly and efficiently. And to many people, they see that as just doing the bare minimum. And I disagree with that approach. I think in acute myocardial infarction, sometimes getting the details right is more important than in a more stable situation. So I'm thinking particularly of, is there any role for imaging within acute myocardial infarction treatment? I think there is, and I think we've seen that with OCT showing plaque rupture and confirms the mechanism. And certainly once you've got the information about the mechanism, and then you've also got the vessel size, you can do an optimized PCI. It's the same with calcium. Now, we come across, particularly in elderly patients, an acute thrombotic occlusion on a very heavily calcified vessel. Sometimes we declare this to be, if we can't cross it, people call it a CTO. But often there are difficult lesions to cross, which have acutely occluded, but on a background of severe, often concentric calcification. And I think there's a body of experience that has built up now in some of the high volume STEMI centres, and certainly my own centre, so working at Harefield, doing the primary angioplasty call. They've been using IVL for since the CE marking, and have introduced it. And because they understand it's safe, they're not going to be using rotational atherectomy. That in fact, in the context of STEMI, if you need to do some calcium modification, by far the safest thing you can do is shockwave.
Yeah, and it's interesting, Jonathan, because I think there's parallels to the wider management of calcific coronary disease, where we've got this new tool now, and all of a sudden we're seeing a granularity to the treatment. If we use the iceberg analogy, actually we're just scraping the surface. Normally we were just scraping the surface with calcific disease, literally with rotational atherectomy, and now we're treating deeper wall calcium and higher volume calcium. And of course, with STEMI, there are multiple mechanisms of acute occlusion as well. The younger patients, it can be plaque rupture and very little role of calcium. In fact, we'll refer the viewer to Module 4, where actually early coronary calcium results in plaque instability. Whereas with the later population, the older population, you get more stable plaque. And actually, but in those populations, you can still get erosion of calcific nodules. So actually, I think we're just starting to understand that actually all STEMIs aren't the same, in the same way as all treatment of coronary calcium is not the same. So I think this is one for watch this space. So thanks for your great talk, and I think we'll move on to the next section of the class. So we've heard about CAD3, and one of the questions that we're asking ourselves is, where do we fit IVL therapy into our algorithmic approach to interventional cardiology and calcific lesions? So with that in mind, it's a real pleasure to welcome Matthew Price. Matthew's going to talk to us from Scripps Clinic in La Jolla, California, about the role of algorithms. So Matthew, a real pleasure to welcome you to the class. Very much looking forward to your talk.
James, thank you so much for the kind invitation. So let's talk about algorithms. When we have a patient who has a high calcium burden in the lesion, what should be our plan of action? How do we assess and decide what to do? So here is a graphic which really lays out all your different options. And we'll walk through this. But essentially, if you have a lesion with a high calcium content in the coronary angiogram, and you start with the procedure, either you can cross the lesion with a microcatheter and a wire, or you can't. So we'll start at the top of our algorithm. So if you have a severe lesion, which you can wire and cross with a microcatheter, but you cannot cross with anything larger than a microcatheter, you're a bit stuck, because you're only going to be able to use either some sort of atherectomy, you switch out your wire, and then optimize with balloon expansion. And then if you still have an undilatable lesion, but you've made enough of a an orifice in the lesion to advance a lithotripsy catheter, you can do that technology and move on to stenting. If you cannot cross with a microcatheter, then you're going to have to basically work over a wire that you can get across, and that'll be either a laser or a atherectomy catheter. Let me focus on the cases where you can actually cross with a wire and potentially a balloon. In those situations, it's going to be important to assess the type and characteristics of the calcium of the lesion. And that's either first pre-dilating, so you can get an imaging catheter down, or just going upfront with upfront imaging. So what's going to be key on the imaging, be it with IVUS or OCT, is to assess the arc of calcification. Does it involve more than half of the circumference of the vessel? Number two is, what is the length of the calcium? Is it a short focal area or a longer area greater than 5 millimeters? And finally, what is the calcium thickness? Is it greater than or equal to about a half a millimeter? So if your lesion has certainly all three or 2 out of the 3, there's a very high likelihood that you'll get stent under expansion if you use a balloon alone. So if you see one or more of those characteristics, you're thinking of using a modality such as intravascular lithotripsy. Another factor you can look at looking at the calcium characteristics is where that calcium is. If you have a high burden of calcium, more than half the arc of the vessel, if it's thick and if it's long, but it is superficial, then you can think about rotational atherectomy or a non-compliant balloon, because that should get expansion. However, if there is medial calcification or deep calcification, that is where lithotripsy may have a particular benefit. Let's walk through some cases. So I think cases tell the story better than words. So here's a patient who is 82 years old with high blood pressure, angina, ventricular tachycardia, and non-sustained, and a high calcium score on imaging. So you see here in the angiogram a lesion in the mid-LAD, which on fluoroscopy alone has the sort of the telltale train tracks of a high calcium burden. So here I'm radial and a 6 French guide. So my decision here was that the lesion appears crossable with a balloon, and there's an adequate lumen for the imaging catheter. So I'm going to do upfront imaging here. I prefer OCT. IVUS would be fine as well, though there are some arguments to be made that OCT is better at characterizing calcification. But I'm going to do upfront imaging to assess the nature of this calcium and determine my approach. Again, and that is because there's enough of a lumen for a imaging catheter. So here is the OCT of this vessel. On the left is the actual run playing. On the right, you see the distal reference area. And on the far right, you see the area of the worst calcification. So there's some fibrotic tissue here, but now you see just at really a bit proximal to the minimal luminal area, a heavy burden of calcification. Let's go back to that. So interestingly, here was the tightest area. And although there is calcification across most of the circumference, it's rather thin. However, coming more proximally, right about here, you have circumferential calcification that is quite thick. In fact, there it is greater than 1 millimeter in some spots. Its length is certainly more than 5 millimeters, and the location is both superficial and deep. And the final piece of information is that the lumen is large enough to pass a balloon. So what are my options? My first option would be a non-compliant balloon, although I would argue that there's a low likelihood of success at the sites of thick circumferential calcification. Atherectomy would not be unreasonable, I think, but the thickness and depth of the calcification and the pretty decent lumen diameter outside of the minimal luminal area probably lowers the likelihood of success, because I won't get enough atherectomy to allow me to expand my stent. So finally, the last option is coronary intravascular lithotripsy. Here again, there's thick circumferential calcification, a reasonable lumen, and deep calcium. So I think coronary IVL was the right choice here, or is the right choice. So here I'm using a 3.0 by 12 IVL catheter balloon. And it's just images on store fluoro of the IVL being delivered at 4 atmospheres of pressure on the balloon. You see the opening of the waist of the balloon, both in the more mid and proximal sections of the lesion. This is the angiogram after IVL. A nice result with it. Look at that, a balloon at only really at maximum 6 atmospheres in that terrible calcification. I do a post-IVL OCT. Here you see very nicely the longitudinal fractures of the IVL catheter. I look at the distal reference vessel to determine my stent size using the EL to EL distance. And so I chose a 3.25 by 38 millimeter drug-eluting stent. Here it is going in at nominal pressure, beautiful expansion. I post-dilate with a 3.25, and this is my final result. So here's an example of upfront imaging, characterizing the lesion and the nature of the calcification, and choosing the most efficient approach possible, a very rapid, quick, painless case. Well, some would argue, and I think it's a reasonable approach, is using what we call pragmatic predilatation. Use a balloon. Do you get expansion? If not, what do you do? So here, this is a kind of lesion where a device can cross quite simply. You may IVUS or OCT up front to determine the balloon size or not. You may not be an imager and you are the type of person who likes to do imaging, and you're going to choose a semi-compliant balloon at nominal pressure. Inflate that balloon. If it dilates, you're off to the races. Proceed to stent implant and post-dilatation. If not, you can switch out to a non-compliant balloon, go to high pressure. There, if it dilates, great. Proceed to stent implantation. But if it doesn't dilate, and now you have a waste in your non-compliant balloon at high pressure, what next? So you could repeat your imaging, and if you haven't done it at first, and decide with our algorithm whether to use a scoring balloon, atherectomy, or IVL. Or you can just go straight up, because you're not an imager, and you can just decide based on what angiographic characteristics. And there is some potential regret if you choose that approach. We'll talk about that. I mentioned the calcification algorithm. There's one additional thing. This is a fairly busy slide, but I want to focus on some things that may guide you in some cases, both for IVL and away from IVL. So first is to look at additional considerations. Let's say you have a calcified lesion. Is that a bifurcation where you want to keep a wire down the side branch? Is it the left main where maybe you don't want to perform atherectomy? Is there a fairly decent lumen already at the lesion site where you may not get sufficient atherectomy? Those are lesions, if you have significant calcification, where you might choose or prefer IVL. If you look at some other characteristics that we know about in terms of calcium, I mentioned the angle, the length, and the thickness. Another thing is to look at the distribution of the calcification. There are some cases where you have a nodule of calcium. And in those situations, rotational atherectomy may be preferred to get that eccentric atherectomy of or remodeling of that calcium to allow for full stent expansion. I think a very easy thing to remember is, hey, when should I use IVL? Well, on imaging, it's greater than 180 degrees of calcification, and or it's thick, and or it's deep, and if there's a sufficient lumen to advance a balloon. Characteristics outside of, or additional characteristics would be left main or osteo right coronary arteries, bifurcations, tortuous anatomy where atherectomy may not be favored. And finally, if you tried atherectomy and you followed with a non-compliant balloon and there was still under expansion of your pre-deal balloon, that's when you have to bail out for IVL. So I do want to focus a little bit though on this aspect here, is if you're using a practical pre-dilatation approach and you do not have expansion of your balloon, some people just jump to an atherectomy catheter without imaging up front. So, and what are the potential hazards of doing that, of not assessing the calcium after you've already ballooned? So here's a case, 76-year-old female with severe angina. You see this quite severe proximal LED lesion. You see on fluoroscopy alone a real heavy burden of calcification. No doubt that is a highly calcified lesion. There's also a highly calcified lesion of the circumflex. So I just went straight with a NC balloon here, and at 20 atmospheres, you see very nicely a significant waist right before the bend. So my options here are atherectomy, a scoring balloon, or coronary IVL. You know, I was a little hesitant to do rotational atherectomy. I certainly could have. It was a little bit tortuous. I thought I had a big enough lumen to get a IVL catheter down. So I think dealer's choice here, I chose IVL. I went straight with IVL. I chose a 3.5 IVL catheter, and you see nice expansion at 4 atmospheres. And then I IVISed after I did my IVL. You see here in the proximal area at the sites of the waist before, very nice fracturing of the circumferential calcification. But I turn your attention to this is the very ostium of the LAD. You have a calcific nodule right here, which I did not assess because I didn't image before. And in fact, I was distracted by the target lesion in the more mid segment. You do see with the IVL a fracture of the calcium nodule. So I would not say IVL is useless in that situation, but one could argue that potentially I would have gotten a better result with rotational atherectomy by addressing this nodular calcification, although the lumen is quite large there. So I just went ahead and pre-dilated further to see if I could get a good result. You see here with the 3.5, I thought I got decent expansion even at that nodule. Here comes my stent, a 3.5 millimeter DES. And now this is the post-stenting OCT. And I just want to focus at this nodule. See, there's good expansion, first of all. We like optimal is greater than 90% expansion. I have greater than 80% expansion throughout the length of my stent here. But there is eccentric expansion at the side of that nodule. So one could argue that potentially imaging after the IVL, or I should say, excuse me, imaging after the pre-dilatation would have allowed me to identify this calcified nodule that in theory might have given a better expansion at the ostium of the vessel. But this is the final result, and I thought it was adequate given my OCT imaging with adequate expansion. If you're worried about this circumflex, I can tell you I brought her back in a couple of weeks. And this, I used a practical pre-dilatation approach for the circumflex, and surprisingly, NC balloons expanded beautifully without any need for calcium modification beyond NC balloons. And you see here after a culotte of the left circumflex and first OM, a really nice final result. So in summary then, how should we integrate calcium modification into clinical practice? I've just highlighted here the different technologies. NC balloon is your first line therapy, particularly if you're using a practical pre-dilatation approach. NC balloons will work with superficial calcification that does not, that's not circumferential, or that's not more than 180 degrees, that is not thick and is not terribly long. IVL is a good option when you have a dog bone balloon, when you have thick, deep calcification, when there are anatomical considerations such as side branches and left main, or other high-risk situations like I had that diffusely diseased LAD. Atherectomy is going to be a go-to device for vessels that you can wire but cannot get a balloon across, for nodular calcification, for thin and intimal calcification, and diffuse calcification. And finally, scoring balloons, we didn't talk about too much, but can be an option, as particularly newer scoring and cutting balloons, when a non-compliant balloon does not expand or you have focal thin calcification. So guys, I will leave it at that, and thank you for the opportunity.
Matthew, that was great. I mean, we've just come from the rarefied environment of CAD3, academic research, and obviously a regulatory study as well. And, you know, it's great to hear that data from the primary investigator, Jonathan, who's taken us through that beautifully. But I guess we were always asking, what does the real world look like for IVL therapy? And you've taken us beautifully through that. And you've also shown the importance of understanding where you're going to get the most value from your intervention. So my first question to you is, have you changed how you've used IVL from your initial inception and adoption of the technology to where you are now? And if so, in what way have you changed?
Right. So I think we need to use IVL efficiently, right? And so now that I have IVL in my hands, I do tend to use upfront IVL a little bit more when I image and I have terribly thick, deep calcification. superficial and deep. Because I know those cases, I can spend a long time pre-dilating, using rotoblator, and then failing with the balloon afterwards, and then finally breaking out IVL, and I've used a lot of equipment. So in those cases where you have a really heavy burden of thick calcification that is deep, I do think those are the rare cases where upfront IVL is efficient and potentially cost saving.
I think those are excellent points, Matthew, because one of the things that people don't quite appreciate with algorithms is actually that's one of the major focuses. They're about efficiency. What's most likely to work? It's a sort of probability map. What's most likely to work in this environment? So I know that you're an imaging enthusiast and Jonathan is as well. So my question to Jonathan and yourself is there a shortcut? Can we use IVL without imaging?
Well, the short answer to that is yes, of course you can, but I think you have to have some appreciation of what calcium burden you're dealing with. Now, I think Matthew and I both have the same approach to the use of intravascular imaging, that our default position for the majority of cases now is to use intravascular imaging for the majority of our cases. I think that's probably fair to say, Matthew. But
yes,
if you have pragmatically imaged the calcium by an alternative method, and by that I mean high definition coronary angiography, many of our imaging systems show us the calcification angiographically, then I would adopt the approach that Matthew's just suggested and go with IVL first, that you know that the most efficient way to complete the procedure, so this is without intravascular imaging, is to deal with the high calcium burden that you've seen on angiography. Now, if you haven't seen a high burden of calcium on angiography, then if you're going to do intravascular imaging, you then may identify that calcium burden that you didn't identify on angiography. But whatever way you do it, I think it's the more efficient way to deal with the vessel modification requirements. And the majority of vessel modification that we're doing now is going to be either with an NC balloon or with IVL. But I think the efficient method, or the most efficient method, will be IVL first.
So listen, let me flip that question to you, Matthew, because actually quite often people are asked to reinforce their position. You know, you're an imaging enthusiast, tell me everything that's good about imaging and you'll be here all day talking about it. And I'll caveat this question by saying my rate of imaging is in the high 90s for all cases. So what is the argument against using intravascular imaging?
Yeah, I mean, I've done plenty. I'm an imaging enthusiast, but I've done plenty of cases, both rotation and IVL, without imaging. So I think then how do you do that is that practical approach. I mean, first use fluoroscopy. You can see the calcification. See, test it with a balloon. Does it crack? If it doesn't, and you have a decent lumen, go to IVL. If you can barely get a balloon across, choose rotational atherectomy. I think where you need to be careful, and I think my case showed, several of my cases showed this, is that often where you end up having a problem with calcium is a little bit outside the minimal luminal area of the lesion. Okay, and for example, and I'm sure many of you have seen this. If you've done a case, you've done rotational atherectomy, you got the spot that you thought it was best, and then you put in your stent, and it's a different spot that doesn't expand completely, right? Because, and I showed you in that first case where the area of circumferential thick calcification was just proximal to the minimal luminal area. And in fact, in CAD3, and correct me if I'm wrong, Dr. Hill, but the areas of failure were actually outside the target lesion areas in the vessel that were calcified.
It was interesting to see within the CAD3 patients that the area of maximum expansion that was often at the tightest point so maximum expansion of the stent was often seen at the tightest point of the densest part of the calcium distribution. So the circumferential tight rings of calcium are the ones, once they were modified, expanded more than the other non-modified segments of the lesion.
But you see this effect, of course, Matthew and Jonathan, all the time, irrespective of calcium, that, there's an issue the way we behave with lesions, that we're often drawn to the tightest lesion. we treat it, and all of a sudden the rest of the vessel looks like a dog's dinner. And that does bring us back to what is the goal of therapy. Mm-hmm. And actually, if the goal of therapy is luminal gain, then our restoration of vascular compliance, we have to be meticulous in not just focusing on concentric calcium, but perhaps understanding that the concentric calcium, by way of contrast, will take less effort to treat than the eccentric calcium in terms of pulse management. And that may be a nuance of IVL therapy that we'll kind of learn with time.
You're going to do IVL without imaging. It's just make sure that you cover the fluoroscopic areas of calcification with the IVL catheter. That involves some pulse management. But again, I think that's a very straightforward approach you can use, and you don't necessarily need to image.
Mm-hmm. So, Matthew, whilst we have you on the line here, going back to the CAD3 OCT Substudy, I think you were one of the main contributors, along with Richard Schlofmitz, to these patients. What did we learn about the mechanism of action? And specifically, what did OCT tell us about the mechanism of action? And just how do you reconcile the presence or absence of fractures and the correlation with the degree of stent expansion?
Right, well, if in the OCT substudy, longitudinal fractures were seen in a majority of patients after IVL, but there was still good stent expansion in patients without fractures that could be seen on OCT. So there's a little bit of a conundrum. One explanation, and you see this on micro OCT, for example, is that there are longitudinal fractures after IVL that are too thin or small to be seen by OCT. My takeaway from the OCT substudy is that it's not required to image after IVL and before you proceed to confirm you got a good result by IVL. How I determine whether my IVL has been a therapeutic intervention is whether I get full expansion of the IVL balloon during lithotripsy administration. So that is a non-imaging, but it's an angiographic, fluoroscopic determination of whether I've done enough IVL, if I've used a one-to-one balloon.
Yeah, and actually I'd refer the viewers to webinar 4, class 4, when we talked about the mechanisms of action. And this exact question came up, Matthew, about microfractures and what it was we were missing in OCT. And actually the fact that most of the time we're using anatomy as a surrogate marker of vascular compliance, because we don't have a physiological way to measure vascular compliance, but essentially that's what you're saying, is the compliance of the vessel sufficiently high that we can implant a stent without experiencing recoil. And it is interesting. I have to say I would reserve being too definitive about not using imaging after therapy based on probably a relatively small study, but it is one of those head scratchers that actually, if your stent is expanding, you've restored vascular compliance. It's just that we're using a surrogate marker for that in terms of anatomy. So listen, Matthew, it's been great chatting to you. It's clear that your IVL experience has been very in-depth, and you brought a lot of that to the audience today, and we very much thank you for that. So final question is this a game changer? Is it here to stay, or is it not going to be adopted in your practice?
Well, I mean, I think it's become a foundational piece in the cath lab in terms of efficiency of cases, bailing out in cases where you have lack of expansion of the balloon in a lumen that's a little bit too large to perform atherectomy. So it's certainly here to stay, and I look forward in the years to come of continuing to optimize when and how to use coronary IVL.
So, well, thank you on that excellent note. We'll just leave you to get back to your work there. You've clearly got a few gaps in your wall that you could put a couple of more certificates up. So, there you go. Yeah. There you go. There's a big one required there. So listen, thanks, Matthew. I'm sure it's a sunny day in California, and it's been great having you here today. Take care.
Thank you.
Okay. Thanks, Matthew. And to add to this discussion, we're lucky to be joined by Benjamin Honton from France, who is reviewing IVL data to date and asking where are the gaps. Benjamin, thanks for joining us today.
Dear Jonathan and James, thank you for your kind invitation and share with you where we could find gaps in IVL evidence according to the current literature. So as you know, and you describe it, IVL evidence come from the disrupt clinical program with the CAD1, the first-in-man, the CAD2, the post-market registry, and finally the CAD3, which was the worldwide study for the FDA approval. But you know that in this kind of study, patients are highly selected, but also clinical indication. And so far, we can find again today gaps in evidence in our daily practice for the use of IVL. And first of all, I think it's gaps in indication. And as always, the devil is in the detail. If you take the inclusion criteria of the CAD3, you can see that patients were selected if they had reference vessel diameters of 2.5 to 4 millimeters, excluding small vessel and big vessel, but also with a lesion length below 40 millimeters, excluding long lesion. And if we go deeper on the exclusion criteria, we can see that in the protocol of CAD3, asymptotic score, target lesion in an osteal location, unprotected left lesion, and possible thrombus, and so far acute coronary syndrome were excluded from the study. And so there is still anatomical gaps in IVL literature concerning the complex lesion, the left main lesion, the osteal lesion, bifurcation, chronic total occlusion. Patients were not enrolled in a disrupt clinical program. Fortunately, there is some evidence coming from the daily practice, and James, you have published this nicely retrospective study on nearly 30 patients on the efficacy and safety of use of IVL in left main, with a significant increasing of MSA in each segment treated by IVL. And this retrospective study was highlighted by another one conducted by Carlos Salazar and Javier Escanet team, who show in the same time the efficacy of IVL and giving advice on how to use IVL in left main calcified stenosis. But there's still also gaps in the study design. As you know, all the CAD study development program was a prospective multi-center, single-arm studies. And IVL is suffering from a lack of comparator like arteriotomy or modified balloon, and in the best way with a randomization fashion. I think there is also a gap in study design with a relative weakness of primary procedural success definition, which was defined in the CAD3 protocol as a stent delivery without residual stenosis more than 50%, which is, in my view, very far from what we do in our daily practice. This is a relative weakness because of the use of a predicate study and the use of the effectiveness performance goal as an endpoint in CAD3. The weakness of this procedural success is decreased by this kind of statistical analysis. But there is also gaps in procedural approach. And there is still two unanswered remaining questions, which is the optimal number of post-delivery, but also, do we need a post-IVL dilatation before stenting? And if we go on disrupt CAD3 data, you can see that the mean IVL pulses is nearly 70, but with a large side deviation of nearly 30% of IVL pulse in the patient. So a large heterogeneity between the lesion and the operator. Interestingly, there is only 20% of post-IVL dilatation before stent implantation. And when we compare with what we do in our daily practice with this observatory published by Axori and team, you can see that in this cohort split in 3 groups, there is a large heterogeneity on the number of pulse applied on the lesion, but also a large heterogeneity on the use of post-IVL high-pressure dilatation before stenting, coming from 20% to 50% of the patient. And so there is no consensus, actually, on the answer we have to bring to these 2 questions. number of pulse, and post-IVL dilatation. If we go on the CAD3 protocol, it was mandatory for the operator to post-dilate after IVL if there is a residual stenosis more than 50%, and maybe we can use this definition to have comparison between the study. So to sum up, I think IVL is definitely a promising and appealing technique, but it's still a young technique. And as patients have been highly selected, clinical indication have been highly selected in CAD studies, we will need data coming from all comers patients in our daily cath lab with large-scale registry, but also the use of sharing experience of the operator, like in this kind of masterclass, to bring the best of IVL in our cath lab. Thank you very much for your attention.
Benjamin, that's fantastic. Thank you for that overview. I've got Jonathan here with me in the studio as well, and if you don't mind, we'll ask you a couple of questions about your perspective on the data. And so we start kind of broad spectrum, as it were. So studies are often designed for commercial or regulatory reasons. And I think actually, as you alluded to in your talk, sometimes they have limited real-world applicability. What do you think is the most important thing for a new technology to be able to demonstrate?
First of all, I think for a new technology, safety is the main point. And for that purpose, I think IVL show that the safety in CAD3 study is very good and probably applicable to the real data in our daily practice. The second one, of course, is efficacy, and you have shown that in left main it is useful. Of course, we have to say enroll because these two studies remain with a modest sample of patients, but it's a first point. And so far, if we want to prove the efficacy of IVL, we will need a comparator. And we know that teams are working on trial with comparison with atherectomy device in a randomized fashion, and it will bring a good level of science to show efficacy in our daily practice in this kind of study.
I know we're lucky to have Jonathan here, who's the lead investigator from CAD3. So Jonathan is looking keenly at you. I'm sure he's about to launch you a few difficult questions. So I'll hand over to Jonathan.
So Benjamin, I was interested to hear your take on how IVL is going to progress beyond the CAD series of studies. If you were to pick one application, one lesion where IVL is going to be most impactful that wasn't included within the CAD3 study population, what would be that one lesion subset you would go for?
Thank you, Jonathan. If I have to choose only one lesion, it would be definitely the osteum of the right coronary artery, with disease coming from the aorta, which is often associated with recoil, often associated with large osteum, and so far large burr if we need to make a debulking and complication related to large burr. So if I have to focus, it would be on the osteum, more the right coronary, because it's more often than the left main osteum, but also in the left main. Definitely osteal lesion in actually evidence.
So you've had quite a number of years of experience of what we would say is now real-world usage. And how do you see IVL integrating into your practice, and perhaps with newer operators, how would you recommend that they integrate IVL into their practice?
I think one major advantage of IVL is that the learning curve is very easy. Of course, you have to know some tips and tricks, but when you're comparing with atherectomy, it's much more easier. So definitely, and you present it in your algorithm, the decision of use of IVL will increase even for young practitioners. The problem is the costs. We know it's different from different countries. Actually, in France, there is no reimbursement of IVL, which can limit it, which is a limit for the use of IVL in daily practice. But probably we are working on that. And at the time where IVL will be reimbursement in France, there is probably a daily use in all the cath lab in France, according to the augmentation of calcified lesion.
So just developing that further, looking at the newer operators and people considering taking on one of the new tools for calcium modification, would you go to IVL before you go to rotational atherectomy? How does it fit within the pathway? How are you going to recommend that you develop a calcium modification pathway? Is it IVL first or is it rota first?
I think that in every operation we did, you know that the preparation of the intervention is important and the selection of the patient. Of course, if there is a diffuse lung disease, uncrossable lesion, we will not go for IVL first because we know that we will fail. And so it depends always on the angiogram analysis, and something which is very important for the young operator is to learn all the situations that we can see. We can have a failure of IVL or a failure of atherectomy, and that's this point that we have to share with the young practitioner.
You've been great today, Benjamin. We've enjoyed tapping into your brain and designing what studies Shockwave needs for the future to find its place within calcium modification. Listen, Benjamin, it's been a real pleasure to have you here and hear your thoughts on the research portfolio. I know we're going to be sharing some more information on, I think, Shockwave's kind of global kind of research designs, Jonathan. So it's been fantastic to hear from you, Benjamin, and thank you again today.
Thank you so much for your kind invitation, James and Jonathan. Thank you so much.
So Benjamin mentioned about various unmet needs, and in particular, I think one that you have a specialist interest in is treatment of left main stem disease.
Yeah.
So after the granting of the CE mark and the CAD 1, 2, 3, 4 programs were carrying on, and patients were being recruited into those programs, I think you became quite interested in how you were going to introduce IVL into your complex PCI practice, and in particular with the treatment of left main. So I wonder if you could just describe to us the first case that you did with IVL in the left main and why you thought that it might help in this particular lesion subset.
Yeah, so I'll take a step back from that, Jonathan, and I would say actually one of the challenges of IVL is economic. And when people talk about money, they start to kind of lose sight of goals of therapy. So I like to reorientate that discussion into one of value. And I think value matters a lot to every stakeholder involved in this process. It matters to the managers of the whatever environment you're working in. It matters to the physicians, but most of all, it matters to the patients. And from a patient's perspective, value means that whatever process they go through, that they get the result that makes a difference to them. Now that process can, within an NHS environment, not involve money, but it does involve apprehension, fear, sometimes morbidity, sometimes a recovery, and that's an investment. Whether it's a financial investment or an emotional investment or sometimes even a physical investment, it's an investment. And you don't do that without a return. And actually, we should be very aware of that with every procedure we do. And it struck me early on that with lithotripsy, you wanted to demonstrate value. It wasn't just about cracking calcium, it was about delivering value to patients. And what better way to deliver value than in a lesion subset with an unparalleled evidence base that it's prognostic. It actually shortens patients' lives if it's not adequately treated. And that actually, in terms of the treatment options, one is associated with a very high degree of morbidity, coronary artery bypass grafting, where the recovery can be 3 to 6 months, and in elderly patients, they can never recover fully. And of course, we know with calcific coronary disease that these are largely elderly patients. So it struck me that if we could give them the same percutaneous benefit as coronary artery bypass grafting, we really would be delivering value. So that's why I oriented on this pretty early, because I think in terms of percutaneous coronary artery disease, there isn't an area where you can add more value, really, with the exception of maybe, STEMI or acute coronary syndromes. In terms of the first initial case, it may be the case we did together, I think, in King's, wasn't it, where we had a patient with very heavily calcified bifurcation disease, and this gentleman was quite overweight. He'd actually presented with heart failure, so he worked with horses, and he couldn't actually do any work with horses, so he wasn't getting any real joy out of his life. He had severely impaired ejection fraction, and he was not considered to be a good surgical candidate. And we didn't have an option. And I think before Shockwave, we wouldn't have had an option, full stop. And I think you and I did that as a live case to Tokyo or somewhere like that. And his life was transformed. We got a great result clinically. More importantly, he's back to doing all the things that he wanted to do. And I think, to my mind, that was, I guess, it's, anecdotes drive behavior. It definitely was a kind of powerful demonstration of the efficacy of the technique. But, ultimately, we should be scientists, and we have to take a step back from that and ask the hard questions. Is it will work in every situation? Well, of course not, but let's ask that question properly. So we're actually running a very tightly controlled left main study, multi-center study, where we'll be looking at imaging-based outcomes and planning a more randomized study on the basis of that. But early on, our experiences have been very positive. That it's a high-value area, and it does seem to deliver value to patients.
So, anecdotes and individual cases aside, in this current context now that as interventionists, we face I think a pushback against the treatment of left main disease following Noble and Excel. So doing a left main study in this current environment with a new technology, has that been, from an ethical perspective, has there been a challenge to you setting up and running this study?
Yeah, listen, I don't really see that as a kind of a controversy. I think here we are in the middle of a COVID pandemic where the volumes of coronary artery bypass grafting have plummeted, where the volumes of all elective interventions have plummeted, where we have hospitals clogged up with, unfortunately, patients with COVID. And in societies where COVID has been less endemic at the moment, like the UK, we still have hospitals which are clogged up with waiting lists and with processes to deal with COVID. So to my mind, the rationale for percutaneous treatment and early safe discharge of patients is more robust than ever. And again, I'm not also a believer of the argument that surgery offers much of a mortality advantage. We're down to morbidity. And then you're arguing about which morbidity matters more. Is it the morbidity of a repeat PCI, or is it the morbidity of a stroke, or a 3-month recovery, or a 6-month recovery, or depression of rates of 70% at 1 year? So, there's a choice either way. It isn't always A or B. There's often, I think, our choices should be very patient-focused and patient-centric. But the overall view of the situation as we are at the moment is that if you can deal with patients safely and durably percutaneously, then that's the preferred option.
So specifically with IVL and the safety in the treatment of left main, how would you compare an IVL procedure with, say, rotational atherectomy? Do you see it as a safer procedure?
Yeah, I don't see it as a procedure at all, really. I think IVL is a therapy, a tool, which is part of a procedure. And I think if we start kind of subcategorizing procedures into X, Y, based on the hardware we use, we're losing sight of our goals again. So I don't think that we should say it's one or the other. And we've done many procedures where we've used, rotational atherectomy and IVL therapy. And it's what it takes. The reason that we focused on the left main is that actually because the value that we're offering, potential value we're offering is so large that actually, if we use two relatively expensive technologies, it matters much less. And our competitive technology, of course, is coronary artery bypass grafting, which is, in most economic calculations, 3 or 4 times as expensive. So again, you're very much on safe grounds to do the right thing for the patients, and of course that's why we're all doing what we do, Jonathan.
So this is going to be a study which will use intravascular imaging. What do you expect that you will show in terms of the your ability to expand stents fully to the maximum diameter from what you've seen so far in the cases that you've done, and I think you've done a large number of these cases already. What are you seeing in terms of how effective it is in maximizing your stent expansion?
I think it's highly effective, but at the same time, these are arteries which have undergone huge amounts of positive remodeling. And there is a limit to what the adventitia can grow to. And I think we have to be pragmatic in our goals. So I think our goals will be probably more pragmatic than they would be in fibrotic or soft plaque, where we can aim for 90% of distal lumen area and so on. I think we have reasonable data from Excel, the sub-studies of Excel. I wish that had been done a little bit different from the way it was done, but we have reasonable data that if we get to certain MSAs in the left main and also in the ostium of the circ and the ostium of the LED, we can be confident of the durability of our results. And I think the thing I really like about the imaging is it's objective. It's not me saying it's a great procedure, it's numbers. And we can compare those numbers to published data. So I think we're giving ourselves a challenge with this study. We've gone into a very complex, high-risk lesion subset, but I'm confident based on the pilot data that we've produced to date that we can match the outcomes that we're seeing in the best cohort in Excel.
So when do you think you'll be able to come and report the results? How soon do you think we'll have some data to look at?
Well, I would hope by the end of this year we'll be in a position to discuss the results. Unfortunately, COVID made a fairly negative impact on a lot of research, but we're just getting back up and running now, and I think we've got a great bunch of centres on board, so I'd be hopeful by the end of the year we'll be back and able to discuss the results.
Great. We look forward to it. Thanks, James.
For a different perspective on IVL therapy, Ashok Seth is with us from New Delhi to talk about the Indian experience. Ashok, thanks for joining us.
Thank you very much, James, for that lovely introduction. Great to see you, and great to see you, Jonathan. Today, I'm going to talk about the Indian experience in heavily calcified lesions in the real world. We well realize that over the last decade, the proportion of heavily calcified lesions in our clinical practice has increased exponentially for a variety of reasons. And at the same time, in parallel, we have now a variety of devices to treat these heavily calcified lesions, and also a better understanding of these lesions and the choice of therapies through intravascular imaging. Clearly, what stands out most is that intravascular lithotripsy seems to be a preferred choice at the moment, with the ease of use, with the short learning curve that we have with this device, and with the low incidence of complications associated with intravascular lithotripsy. Though I must emphasize that all these devices find their use when we deal with complex, heavily calcified lesions. Now, the first case of intravascular lithotripsy in India was performed by us in January of 2020. It was a live case at the second CHIP CTO meeting, which we organized, and it was proctored by, thank you, Jonathan Hill, for getting us off the ground. Since then, over the last 1.5 years, the total number of cases done in India have been 1,300 plus, and a Shock India registry is on the anvil for real-world cases. I must say right in the beginning that this is my algorithm for coronary calcified lesions in the real world. It starts off with angiographic evaluation, and I won't take you through this in detail, apart from emphasizing a single point, and that is for severely calcified lesion, I consider in our practice, keeping the right balances of time, cost, as well as safety and efficacy, intravascular imaging upfront for severely calcified lesion when the balloon crosses. But for mild to moderate calcification in our practice, I would rather test these out with a non-compliant balloon at high pressures, and those who failed the test of dilating with a non-compliant balloon would progress on to intravascular imaging. But here in today's discussion, I'm going to talk about heavily calcified lesions, not mild to moderate calcification. And the learnings from the real-world cases of IVL in this subgroup of patients revolves around using IVL as bailout for failure to dilate calcified lesions, could be upfront use of IVL based on intravascular imaging, which I told you is my upfront strategy in severely and heavily calcified lesions, in complex calcified lesions. And of course, we will actually see a few cases of device synergy for facilitation of IVL or for result optimization, and of course, off-label use of IVL in underexpanded stents. So let's go on to the first case and start understanding what we learned from these cases. This is a 75-year-old male, presents for primary PCI at another center. And you can see that the operator had a difficulty in crossing that heavily calcified area in the proximal to mid segment, inability to cross a microcatheter or a balloon, poor guide catheter support, the guide is backing out. And then finally, after getting 2 wires down that vessel, the operator is able to get a balloon across. This is a compliant balloon blown up at 18 atmospheres. A non-compliant balloon won't cross. And finally, the procedure is abandoned with a TIMI 2 flow, at least had the flow having been restored. Of course, the patient continues to have chest pain, presents to me 5 days later, and you can see, yes, there is a poor guide catheter support, and there's, apart from that high-grade lesion, calcified lesion, proximally, there's thrombus in that vessel. AL2 guide also doesn't, AL1 guide is certainly not coaxial, would not allow rotational atherectomy in this instance. And I proceed then to a Judkin guide with a guide liner. And obviously we know that I'm unable to pass an OCT catheter to analyze this lesion, and therefore in the presence of a known calcified constriction there, as you can see, and in the presence of thrombus, my next choice became not a rotational atherectomy, but an excimer laser. So the ELCA 0.9 millimeter catheter is passed down. Yes, it did take its time at 80 pulses to actually cross that area. And at 80, it did cross that area, and then we passed the ELCA downstream all the way and did 3 passes on that. That restored the flow in the vessel, that treated the vessel, but despite excimer laser, the 2.5 millimeter non-compliant balloon would not open up that lesion at 28 atmospheres. And of course, that allowed us to do an OCT and analyze the lesion, which showed concentric thick calcium, 360 degree arc greater than 1 millimeter calcium at that point where the vessel is not would not be dilated. Actually, a case truly for IVL. As you can see, a 3.5 millimeter IVL was selected, though actually the vessel is 4, and I should have taken a 4. In fact, the text passed me the 3.5 we were discussing, the size of the IVL to be chosen. And you would note on the left side that after 40 pulses, the lesion does give way. Pulses were delivered along the vessel, but maximum pulses was at site of this lesion. And you can see on the right side that the balloon is fully dilated after 80 pulses. Post-IVL analysis demonstrates adequate fracture of the calcium at the tightest lesion point. And subsequently, a 4 into 38 millimeter drug-eluting stent is implanted, blown up with a non-compliant balloon, which still shows some residual stenosis of greater than 20% at the tightest point, and that may be due to the fact that I was undersized with the IVL for the vessel. And then an OPN, ultra-high pressure balloon, is taken up to 35 atmospheres to relieve that residual stenosis, giving us a great final result, as you can see in the left side angiogram. And of course, we have a lumen of 12 square millimeters at the tightest point where the vessel was not being dilated. I had concentric, thick, deep calcification. So this case tells us about the device synergy, laser plus IVL plus OPN, where laser facilitated the crossability, IVL did the real job, and the OPN optimized the stent implantation with ultra-high pressures. We understood that IVL allows safe and effective expansion, but we do need imaging to size our IVLs and for ultra-high pressure post-dilatation with safety. Now, this is a very illustrative and interesting case of a 59-year-old male who's a diabetic, who's had previous mid-LAD stent and now has a proximal LAD lesion. Now, most people would look at this and say, this is no big deal, just a bit of calcium seen on the angiogram. We should just go ahead, dilate this, stent it, and this should be my fellow's case rather than my personal case. Well, this is how it goes in our understanding. We said upfront imaging, the upfront imaging demonstrated to us concentric calcification, but deep calcification irregularly distributed, nearly 1.3 millimeters on one side and 0.8 millimeters on the other side. Well, clearly, upfront use of IVL was the next step. A 3 millimeter IVL based on the vessel size showed complete expansion in the second cycle, as you can see on the left side. And by fourth cycle, which is 40 pulses, the balloon was completely expanded in this view. Well, with that, we also did an OCT and saw adequate fractures in the calcified segment, as can be seen here, and therefore proceeded to a stent implantation and optimization with a 3 millimeter non-compliant balloon at 80 atmospheres, getting a perfect result. And I guess nobody would deny that this is a perfect result. In fact, even an overexpanded stent, doing everything correctly. We just wanted to optimize the proximal edge of the stent by 3.5 millimeter and went to RO projection. To our surprise, we saw significant underexpansion of the stent due to eccentric heavy load of calcification. We'd already implanted a stent at the other view where it was looking even overdilated in the epicranial projection. And here, a 3 millimeter non-compliant balloon at 26 atmospheres does not relieve the residual stenosis. And therefore, that is followed up by the remaining 40 pulses of IVL, which we hadn't delivered, which we now deliver inside the stent. And even after the delivery of the 40 pulses inside the stent, there's still a significant residual stenosis. And therefore, on OCT, we check that and we find that there's elliptical stent expansion with an area of 3.82 square millimeters at that very point, which on epicranial shows perfectly well as a well-expanded stent, and on the RO caudal projection shows as an underexpanded stent. And obviously, we then go in with an OPN at ultra-high pressures of 40 atmospheres. We relieve the stenosis marginally and get an adequate result, which in AP projection looks overexpanded. But certainly, that underexpanded area has now improved to 5.16 millimeters, and that was the end of that procedure. Again, teaching us some very important points that for expansion of the IVL balloon, we must look at both views to see that in a heavily calcified, even concentric lesion, that we've expanded it. When we look at fractures, we must look at fractures not in the weakest area of the vessel, but in the thickest area of the vessel as well, in where the deepest and the thickest calcification is. And on occasions, we got to understand the calcium more better. Maybe rototripsy with a guide wire bias could have eliminated or at least helped to decrease that eccentric, deep, thick chunk of calcification. And certainly, final message is don't chase residual stenosis. These will open eccentrically, and then we've got to rely on the MSA rather than rely on the residual stenosis. Otherwise, we could rupture the vessel. Let's proceed to the 76-year-old male who's a diabetic smoker. He's got a long diffuse LAD disease. You can see that here. He's also got calcified circumflex. The circumflex is rotablated and stented with a drug-eluting stent, as you'll see on the right side, with a perfect result. Well, the same burr is passed down the LAD, but even after 2 minutes of burr time, does not cross that proximal segment as is seen on the left side. Therefore, a balloon dilatation with a non-compliant 2 millimeter balloon is done to facilitate the advancement of the rotor burr. And then, of course, the rotor burr cannot cross the distalmost part of the lesion, and that's 3 minutes of burring time on the left side. And then a 2 millimeter the balloon which we use for the proximal segment, we inflate that to 26 atmospheres to relieve the stenosis, and it bursts. And therefore, this is again a case of bailout IVL through a guide extension catheter, and IVL is delivered to the distalmost part of that lesion, which is where the balloon burst and where the rotor could not cross. Shock waves are delivered at that point, and that lesion gives way efficiently, even in the 20 pulses. The remaining pulses are delivered to the along the length of the vessel to the ostium. Two stents are implanted, inflated to 3 millimeters, post-dilated with a 3 millimeters balloon, with a perfect result on OCT evaluation, as you can see, with a lumen area with an MSA of 8.1, 8.2, and a precision placement of the stent right up to the ostium of the circumflex, ostium of the LAD, without covering the circumflex. So here is the message from this case, that IVL for lesion treatment works with safety even when rotational atherectomy may fail because of the inherent limitations of many of the other devices. IVL is more balloon-like. Here's a case of 100% proximal LAD with a circumflex which is tortuous and calcified. This is clearly upfront IVL because rotational atherectomy would be fraught with perforations, and a balloon, even non-compliant balloon dilatation, would be inadequate preparation for this vessel. Having opened up the LAD, 30 pulses were delivered on the LAD, and the remaining 50 pulses were reserved for delivering it into the circumflex. This was 3 millimeter IVL. Having done that, a stent was implanted into the circumflex, and you can see here that there's a residual stenosis, which is seen after high pressure dilatation at the ostium of that OM, where the stent transitions from the main circumflex into the OM. So an OP, an ultra high pressure balloon, was taken up to 40 atmospheres at that point, which looks adequately dilated. However, and of course the LAD was stented and optimized. But however, if you actually see still, the circumflex does show an indentation at the origin of the OM. And so an imaging was done to decipher that. And lo and behold, what we were treating and trying to optimize was a calcified nodule, and there was stent malapposition prior to that calcium nodule, obviously related to the inability for the stent to expand there. That malapposition was partially treated with a 3.5 millimeter NC, but we did not further go on to that point of indentation, and finally had this result, which is good, but it certainly taught us that upfront imaging is very important for heavily calcified lesions to understand lesion morphology, because we kept on chasing what was a calcium nodule, and we could have actually had a perforation in that vessel. So let's not chase calcified nodules and eccentric calcification. And had I seen the calcium nodule, I may have taken a new OPN for the circumflex and delivered my 80 pulses at that point. Now, we're coming to our last two cases of great learning experiences. This is an 80-year-old male. 6 months ago, had a PCI at another center. 1% was possible in the mid-LAD, mid-RCA, which was underexpanded. The distal lesion in this RCA could only be ballooned. This patient returned. This came to us with class 4 angina, and we therefore proceeded to deal with it. You can actually see that this is an ultimate support. A long sheath was needed. AL1 guide was needed because it was upgoing RCA, heavily calcified, Grand Slam wire, and a guide extension catheter was needed. A 2 millimeter balloon, a microcatheter would not go across the distal lesion, so the distal lesion was rotablated. And finally, after rotational atherectomy, having reviewed everything and having reviewed the fact that there's dense calcification, there's concentric calcification, there's stunt and underexpansion, we therefore proceeded to an IVL on this, and an 3.5 millimeter IVL was delivered to a guide extension catheter, and the vessel was shock-waved right up to the proximal segment and the lesion and the stent itself, intrastent itself. After that, 4 millimeter stents were implanted. Extra high pressure implantations had been done. And this is the final result, which you can see. Nice vessel, open vessel, and a good result in those areas which was stent under expansion area of 7.6 millimeter square, and an MSA of 9.8 even in the proximal segment. Finally, 77-year-old male, class 4 symptoms, diabetic. Imaging was not feasible in this case. It's highly complex bifurcation. Finally, with difficulty, we got the wire into that circumflex. Obviously, we therefore proceeded to rotablate this with a 1.25 millimeter burr in the circumflex, and followed that up with a 1.5 millimeter burr in the left main and LAD, or 1.75 millimeter burr in the left main and LAD. Having done that, we did an intravascular imaging, intravascular ultrasound, and we found deep eccentric calcification at the ostia of the circumflex as well as the LAD, and therefore it was an obvious choice to proceed to intravascular lithotripsy for these ostias. 3 millimeter IVL, 4 cycles were delivered to the ostia of the LAD, and a further 4 cycles into the LAD, ostia of the circumflex, and further 4 cycles into the LAD right up to the ostia. The balloon had a leak, and therefore this is a second balloon was used. Finally, stents were implanted in a mini crush single kiss technique with final kissing balloon dilatation and pot. And this is a final result, as is seen on the right side, a very adequate result, both angiographically and on IVUS, whereby we had achieved a left main MSA of 15.6, a circumflex ostial MSA of 8.6, and a proximal LAD of 7.6, which would not have been possible without the use of IVL in this situation. So therefore, to conclude my talk and the learnings we've achieved from real-life cases in complex, heavily calcified lesions, is that intravascular imaging has given us increased understanding on the treatment of these very complex calcified lesions. And it's now become a science and an art. And that's what the algorithms have been designed for. IVL clearly stands out as a most user-friendly device, which is safe and effective in the most difficult cases, as you've seen here. And the devices for treatment of calcified lesions, especially in the complex, heavily calcified lesions, are not competitive. They're complementary. And therefore, we need to understand the use of these devices in the appropriate scenarios with best safety and outcomes for the patients. Thank you very much for your attention.
Great job, Ashok. Really enjoyed that excellent presentation. It certainly looks like you've got some pretty serious cases going on in India there. So this is my first question to you is, has there been an evolution in how you've used IVL from when you first started with it to where you are now? And if so, how would you explain that to the audience? Right.
I think the evolution certainly has been that I have really moved to more upfront use of IVL. It's a user-friendly device, it's a safe device. And I think the way I differentiate it, but then on the other hand, in the real life, you've got to balance out the costs also. And that's an important factor, as you can understand, in many parts of the world. And the way I balance out costs is that in heavily calcified lesions, if it's less than a 2.75 millimeters, I would do upfront, certainly upfront imaging, but I lean towards rotational atherectomy or atherectomy for smaller vessels, because I know that even my 1.5 or a 1.75 burr may get into deep calcification and give me adequate atherectomy for subsequent dilatation. But for larger vessels, which is 3 and above, I lean towards IVL as the first upfront choice, because it has a greater chance of disrupting and capping deep calcification and give me uniform expansion. I always know that I have IVL as a backup for any areas which may not expand, for any situations where a balloon may not give me adequate expansion. And that is the reason why I have differentiated between the two. Certainly, for mild to moderate calcifications, I'd rather dilate with a quarter-sized lower balloon at high pressures of 16, 20 atmospheres, and only if that balloon does not expand the lesion completely, and if there's a residual stenosis, I have the backup of an IVL. So yes, upfront use of IVL in larger vessels, and perhaps other devices in smaller vessels, knowing that I have an IVL to back myself up.
Excellent answer, Ashok. Jonathan?
So Ashok, really a tour de force of in those cases. I'm particularly interested in your use of IVL in eccentric lesions. And I think when we started, we were thinking of the prototypical lesion as a concentric calcified ring. And certainly the very first case you showed, demonstrated that. But you also have shown really some outstanding results with good stent expansion in eccentric lesions. Can you just give us some more detail about your understanding about the mechanism of action in eccentric calcium?
Yeah, my understanding, as my experience has grown over this, and as certainly amongst as multiple device uses, is that understanding the lesion right up front is very important. And even if it's concentric, if it is irregularly distributed thickness, then knowing perhaps an ablation with atherectomy, and I've got to prove this in my subsequent cases, ablation with atherectomy could be better than just atherectomy alone, because guide wire biases may get the balloon closer to the deep calcium, especially where it is the thickest. The second aspect is that, yes, be optimal sized and deliver all the pulses at that point. If you saw in my first case, I stopped at 40 pulses because I thought I'd done the lesion adequately. Perhaps I should have, if I delivered my 80 pulses to the lesion, I would have expanded that stenosis adequately. I also did not see the fact that my fractures were at the thinnest point or the weakest point of that concentric calcification rather than in the deep calcification, which led to that electrical expansion of that stent. So there's a lot of learning out here. Perhaps a rototripsy could have been better because of eccentric plaque ablation. Perhaps giving 80 pulses at that point and looking at that vessel in two views would have been better. But clearly, elliptical eccentric lesions would require a lot more pulses, would require optimal balloon size, and certainly not to be chased up for residual stenosis, but an MSA should suffice for most of these lesions. So those have been my learnings from such cases. But also the fact that ultra-high pressures should not be a worry. If one has to optimize and one has done inadequate IVL, remember, IVL should actually give adequate cracking of the calcium and therefore not much need for ultra-high pressure balloon expansions. However, on occasions like this, where there's eccentricity, if the balloon of ultra-high pressure balloon is well sized and optimally sized to the vessel, then one can actually go up to higher and higher pressures to get the best possible MSA in an eccentrically heavily calcified vessel.
And the safety of that is that you've modified the calcium, you've given lots of shocks to that eccentric calcium. So it's not like using an OPN balloon where the calcium has not been softened up or cracked into different pieces. So you're not pushing a big boulder of calcium through the wall of the artery. So it is a safer thing to do once the shockwave modification has been done.
You're so right about that. And that is the reason I think if ultra-high pressure balloon is used without an OPN, that could lead to a rupture. Mm-hmm. With OPN, I'm much more comforted the fact that you will not be rupturing the vessel. There has been concerns, and I must address this, there have been concerns and comments on occasion saying that the IVL could be softening the normal vessel as well, leading to, could lead to perforation, but I would say no. The IVL selectively works on the calcium, softens it up, softens up the hard tissue, but doesn't affect, and I've had no increase in perforations by using ultra-high pressures even after IVL, but have optimized the results better. So you're absolutely right, after IVL.
So let me be devil's advocate, because I don't think he is absolutely right there. If you modify the calcium with IVL, you don't need an OPN balloon. That's a full stop, because the mechanisms are very different. There's a barotrauma which you get from OPN balloon, and there's a differential calcium modification effect which you get from the shock waves on IVL. What we don't understand very fully, and as you say, it's a learning experience, is what is the dose response and how many fractures are enough fractures. Because, of course, you can get in concentric calcium 2 major fractures, and then, of course, essentially half the calcium is still unmodified. But calcium as a mechanical structure doesn't have any elasticity. So it fractures or it doesn't fracture. Yeah. That's it. So if it fractures in sufficient pieces, you're going to get restoration of vessel compliance, and you won't need any subsequent balloon dilatation. The problem is when you haven't insufficiently modified the calcium to need OPN, and then in turn with respect to the kind of risk of perforation, that's almost entirely due to the application of eccentric force to the vessel, not concentric force.
But I think what is happening as the dose of IVL gets higher, as you apply all the shocks, and I think we've had some instances where we've been using more than one balloon in these types of lesion, is that there is also the concept of microfracture as well as macrofracture. So within those big boulders, those boulders themselves have lots of microfractures in them. So I think that's the point that you're making, James, is that they are actually more, you can expand them, they're more elastic effectively at lower pressures.
Yeah, and actually, the point I'm also making is that we use an anatomical substrate for vessel compliance. We look at either an angiogram, which we know is insufficient, or intravascular imaging, like an OCT or an IVUS, and we say there are fractures or there aren't fractures. and we're using the presence of fractures as a substrate for vessel compliance, because we don't have any way to measure vessel compliance. And the other substrate we use is we inflate a balloon, and we say the balloon is up or it's not up. And again, that's a substrate for vessel compliance. So what we're missing here is a way to measure that.
But really the surrogate that you're referring to, MSA, is really a sign that the vessel has become compliant. So if you are achieving a sufficient MSA in the setting of very deep eccentric calcification, then there is a process of modification that's taken place that has allowed the vessel to become more compliant, not just in the non-calcified segment, but within the calcified segment.
There's a comment I have, and James, you're absolutely right in believing that the compliance, if you've done an adequate and optimal IVL, you shouldn't require extra high pressure balloons. Mm-hmm. But in the real world, in long lesions, in diffuse disease, we're sizing our IVL. Because we end up using only one IVL, we size it to the distal vessel, and by the time we get to the proximal segment of that high-grade lesion, we're practically undersized. On occasion, we may end up undersizing our balloons for various reasons, and finally, we may not end up delivering the adequate number of pulses we want at that lesion because we're treating a long segment of the lesion. It would therefore mean that if we went ahead with, at that most difficult point, with a second balloon and gave more pulses, we perhaps would get what we call optimally pliable vessel. But in real instances, some of those lesions which you saw where we went up to ultra-high pressures may not have had an adequately sized balloon for that particular point. You saw there was a 3.5 in a 4 vessel. You saw that the left vein was done close to the ostia with a 3 millimeters because the distal vessel where the lesion had distally was 3 millimeters. I think that those are important aspects to remember, where you do need to go up with a higher pressure balloon. You may need to optimize the MSA better because you have had fractured calcium, but I don't think it's done enough to improve the compliancy in these heavily calcified vessels, which are very complex.
Yeah, no, those are great points, Ashok. It really has been fascinating to hear your experience, which is clearly, quite extensive, and we've learned a lot. So we're very grateful to you for taking your time to share your expertise with Jonathan and I. And as I said, we hope we are able to meet up again soon in person and congratulate you on your fantastic work.
Thank you.
Excellent insights. Thank you so much, Ashok. That takes us neatly to the end of today's session. We hope that you enjoyed it as much as we did. Please join us again here next time for Class 9, when James will be back in the cath lab presenting best practice in large vessel bifurcations, along with Claudia Cosgrove. Kambis Mashieki will be here to explain how to minimize complications in calcium modification, and Simon Walsh will describe the critical role of lesion preparation in calcific left main.
Until next week then, goodbye.
Goodbye.